Unlike life-threatening bleeding in the extremities and junctional regions where the effective use of tourniquets and wound packing can temporarily control bleeding, there are very few, if any, proven interventions to temporarily stop bleeding among patients with severe injuries to the torso, meaning the chest or abdomen, also known as non-compressible torso hemorrhage. One intervention that's gained a lot of popularity as well as notoriety over the last decade or so is known as Reboa, which stands for resuscitative endovascular balloon occlusion of the aorta. Although numerous studies have been published on the use of Reboa both in the pre-hospital as well as in-hospital setting over the last 12 to 14 years, this technology is not at all new. In the early 1950s, Lieutenant Colonel Carl Hughes reported on the use of Reboa in casualties of the Korean War, and in his case series of 2 patients, both of whom expired from exsanguination, Reboa was noted to improve the blood pressure in one of those casualties. Pictured above is the original Reboa catheter used by Colonel Hughes, and here's a picture of a more recent or updated Reboa catheter. Among appropriately selected patients without contraindications to Reboa insertion, the aorta can be accessed via the common femoral artery, typically using ultrasound guidance, or occasionally with an open cut-down approach. Through this, a sheath is inserted through which the Reboa catheter can be deployed. The balloon is then inflated typically in zone 1, just distal to the left subclavian artery, or in zone 3, which is just above the bifurcation of the common iliac arteries, depending on where you think the source of bleeding is. As I alluded to earlier, a number of studies have been published on the use as well as effectiveness of Reboa, either compared to patients undergoing resuscitative thoracotomy or as a standalone adjunct among patients with non-compressible torso hemorrhage. The results overall have been split, and there's been some concerns that industry has played a large role in influencing the results of some of these published studies. To date, there's been no prospective randomized controlled trial on the use of Reboa until last week. The UK Reboa trial, which took place at 16 trauma centers across the UK, was designed as a pragmatic Bayesian sequential randomized controlled trial to assess the effectiveness of Reboa in addition to standard care versus standard care in decreasing the primary outcome of 90-day mortality. Overall, approximately 90 patients were enrolled, and the study authors found that Reboa, in addition to standard care, actually increased 90-day mortality with a high probability. Further, they found that it increased all-cause mortality at all earlier time points. Finally, patients in the standard care plus Reboa arm of the trial were more likely to die of hemorrhage, as well as die of hemorrhage early in their treatment course. The actual paper has yet to be released or published, but once it is, we'll take a good thorough look at the methodology, as well as another interpretation of the results. In the meantime, what do you think? Are you using Reboa at your trauma centers, or was this just a passing fad? Be sure to like and follow for more.